Well, in this video I will try to cover yet another challenging aspect in the cardiac physiology. This graph you're looking at, or what is known as the Wiggers diagram, tends to scare some of our undergraduate students when they look at it, because so many curves, many things that you need to comprehend at the same time. And I would advise you not to do that. I would advise you to try to dissect this graph in front of you. And once you do that, you will be able to correlate each of these curves and each of these graphs to each other. Now you need to understand when you're looking at this graph is that it's not a single graph. We are really piling together the entire, almost the entire cardiac physiology. So you're looking here at the EKG, the electrocardiogram. Then you're looking at several pressure measurements. One of them is the aortic pressure, which is illustrated with this line. And the second is the left ventricular pressure, which is illustrated with this line. And then you have the left atrial pressure, which is then illustrated with this green line. Now, does that mean that we don't have the same events happening on the right side? No, of course they do, but just the pressure is a little different. So in this depiction, we are really just focusing on the left side, but you just need to understand that simultaneously events also takes place in the right side. However, the pressure in the pulmonary artery and in the right ventricle are much lower than what you see here. Okay, so let's go back to what are we looking at? We're looking at the EKG. We're looking at three pressure points: the aortic pressure, left ventricular pressure, and left atrial pressure. Sounds good so far? We're also looking at the volume inside the left ventricle, because that will indicate to us two very important events: the filling and the emptying. We need to understand that the heart is a pump, and so these are the functions of the heart: how it fills and how it empties, sort of the same as any pump. The pump needs to fill and then it needs to empty, and those will be very important for our understanding of the cardiac physiology. The last thing you're looking at here is the heart sounds. You will see that we have the first and second heart sound. There is also a third and fourth heart sounds that you can't generally listen to easily, except maybe with an ultrasound, or in case there is a defect, then those third and fourth heart sounds will be exaggerated. Sounds good? So, yes, we have this very complicated graph, because as you can see, it's piling in the EKG, the aortic valve, the left ventricular pressure, the aortic pressure, the left ventricular pressure, left atrial pressure, and then the volume in the left ventricle and the heart sounds, all of them in one graph. Now we need to dissect that one stage at a time. Before we do that, let's just appreciate the fact that there are two very important aspects here. One of them is in the cardiac cycle, is while the ventricle is contracting. We call that ventricular systole or ventricular systole. Okay? And the other one is during the time in which the ventricles, right and left, are not contracting, and we call that ventricular diastole or diastole. Okay? So, that's very important aspect here to understand and appreciate what is diastole, and sometimes we refer to the heart altogether as a summary of what the ventricle is doing. In another word, when we refer to the systole or the systole, we really mean the ventricular systole, not the atrial systole. Okay? So if you see in some books or in your book that it's abbreviated and we're really talking about the systole, then we are focusing on the ventricular systole. Does it mean that the atria do not contract? Yeah, they do contract, but that is hardly accounted when we are talking about the systole. If you want to be very specific, then there is ventricular systole or ventricular systole, and that will be only the ventricles contracting. So let's just agree to these two events. In one part, you have the ventricles are contracting, and then the other part, which is much bigger, as you can see here, much longer in time, these are in seconds or milliseconds, and so we have a much wider ventricular diastole. Okay, so again, let's go back and dissect these events one stage at a time, and we will see that it's not really as scary as you think. And I would advise you to do the same thing. Take a piece of paper and cover in the same way I'm covering the rest of the graph as we proceed into understanding what the events that happen in each individual stage. Okay, so what I did here is I covered most of it, and I just want to focus on this part. Okay, so let's see. At the EKG level, and we need to understand that nothing happens in the heart. There will be no contraction, there will be no change in the valves without the EKG. So the EKG is the first one, because the EKG will indicate that there is a depolarization of the cardiac muscle. In this case, the depolarization is happening at the atria. So we have depolarization of the atria, and we all know that the depolarization of the atria is causing what you see peripherally in the body as the P wave of your EKG. So, okay, so here we have the EKG showing us depolarization of the atria. That means immediately following this, or in the middle of the depolarization, we must have a contraction of the atria. So aortic pressure, that has nothing to do with the atrial contraction, so we'll just keep going until we get into the left atrial pressure and the left ventricular pressure. What happens when you contract the atria is that you're going to increase the pressure in the atria, and as you increase the pressure in the atria, you will increase the flow from the atria to the ventricle, and from the atrium to the ventricle, we're talking about the left side here, and you can see that the ventricular filling, the left ventricular volume, will increase slightly, about 30%, 20 to 30%, and that is due to the contraction of the atrium. How did the contraction happen? It's because of the depolarization of the atrium. So, once again, depolarization of the atrium caused us to see the P wave. The P wave caused the atrium to contract. Contraction of the atrium will increase the atrial pressure. As you increase the atrial pressure, the blood flow from the atrium to the ventricle will increase, and therefore you have increased ventricular filling. And because of this, and because of the increased contraction of the atrium, the ventricular pressure also will slightly increase. This increase in the ventricular pressure is not that big. We have approximately at about 5 or 7 millimeter mercury. Sounds good? So this is the first event, which is the atrial contraction portion of it. We depolarized the atrium, we contracted the atrium, we pushed the blood out of the atrium, but you will see in a little bit that the blood going from the atrium to the ventricle has preceded this contraction. You don't need the contraction of the atrium to push the blood or to allow the blood to go from the atrium to the ventricle. Matter of fact, most of the blood, about 70 to 80% that fills the ventricle, takes place before the atrial contraction phase. Sounds good? Okay, so that was the first step that we need to understand and appreciate. So what happens next? Well, we agreed that the depolarization of the atrium will go to the AV node and will be slightly delayed, and once it reaches the ventricular muscle, the depolarization wave will reach the ventricular muscle through the bundle of His bundle branches, Purkinje fibers, that will depolarize the ventricles, right? And the depolarization of the ventricles, if you remember, it is going to be shown at the EKG as what we call QRS complex, which is what we are looking at here. This gap between the P wave and the R wave is what we call, sometimes we refer to as PR interval, and the PR interval will indicate the time that the depolarization wave was delayed from the atrium level to the ventricular level. Okay, and that's of course thanks to the delay, the functional delay that takes place at the AV node. We're good? Okay, so that's the first event here that takes place. The P wave was propagated, and that gave us the QRS, which means depolarization of the ventricles. Depolarization of the ventricle will mean contraction of the ventricle. If the ventricle contracts, the pressure inside the ventricle will rise very fast. We agree to that. As the ventricular contraction, and you can see here, is happening, the ventricular pressure is going up, 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 as you can see here. But wait a second, the atrial pressure is not that high. The atrial pressure was about 7 or 10. And so that means the ventricular pressure has exceeded the atrial pressure. And now the blood, which is in the ventricle, is at a much higher pressure than that inside the atrium. Now the blood will try to return back to the left atrium, and that's not going to be allowed because we have a valve here. On the left side we have the mitral valve, on the right side we have the tricuspid valve. Those valves will shut down because the blood is trying to go back to the atrium. Why is the blood trying to go back? Because the pressure inside the ventricles has exceeded the pressure inside the atria, and therefore these valves will shut down, preventing the pressure from going inside the atria to the same level as it goes inside the ventricles. When you shut down these valves, that will cause your first heart sounds. Sounds good? So we shut down the valves at this point. Why did we shut down the valves? Because the ventricular pressure has exceeded that of the atrial pressure. You shut down the valves, you hear the first heart sound. But wait a second, the pressure continues to rise, right? And the blood has nowhere to go. The blood has nowhere to go yet because the pressure inside the aorta is still much higher than the pressure inside the ventricles. The ventricles need to continue the squeezing action until the pressure inside the ventricles exceed that of the aortic pressure, right? In order to allow the blood flow to go from the ventricle, in this case we're talking about the left side, from the left ventricle into the aorta, right? But before that, what happens? So we have a blood volume that now the ventricle is holding, the left ventricle in this case, and we close the valve, the mitral valve, but yet the contraction is happening and nothing yet is being pumped into the aorta. We call that isovolumetric contraction phase. Well, let's explain that, which we can see here. Isovolumetric contraction phase. So iso is equal, volumetric, volume, and ventricular contraction phase because it happens inside the ventricles. Well, that means nothing is changing to the volume of the ventricle. However, the contraction is building. Why isn't anything changing in the volume of the ventricle? Because the ventricle, the ventricles, both of them, they are contracting, but the blood has nowhere to go. So the isovolumetric contraction phase is the place, is the distance or the area between the time of the closure of the atrioventricular valve to the opening of either the aortic or the pulmonary valve. So once again, the isovolumetric contraction phase is the phase that is between the closure of the atrioventricular valves and the opening of the aortic and the pulmonary valves. We call that isovolumetric contraction phase. Isovolumetric ventricular contraction phase, if you want to be very technical. Okay? So that's a very important term here, and to understand that the isovolumetric ventricular contraction phase is between the closure of the AV valves and the opening of the aortic and the pulmonary valve. Sounds good? So volume wise, nothing is changing of that volume, because you can see the left ventricular volume has nowhere to go, right? The blood has nowhere to go because I didn't open this valve yet, and matter of fact, this valve, which is the AV valve, the atrioventricular valve, has shut down, right? So nothing is changing with this volume here, which we call end diastolic volume, because if you remember, this part here was happening before the contraction of the ventricle, so we called it diastole, right, or diastole. So at the end of the diastole, which is this level, this is the maximum amount of blood that was held inside the ventricle, so we call it end diastolic volume, right? It's the volume of the left ventricle at the end of the diastole. At the end of the diastole. Sounds good? Okay. So let's review the second phase here. What happened? We had the depolarization wave passing through the AV node, and that will give us the PR interval. Once it reaches your ventricular muscle, that will cause depolarization of the ventricular muscle, and that is shown here as a QRS. Depolarization of the ventricular muscle will cause contraction of the ventricles, and that will increase the pressure significantly inside the ventricles, increasing the pressure beyond the point where the pressure is in the left atrium. We're talking here the left. The same events happen in the right. That will cause the atrioventricular valves to close, and that will produce to us the fast heart sound, right? The pressure continues to rise, but the blood has nowhere to go, and that's why we call this phase isovolumetric ventricular contraction phase. Sounds good? Let's go to the phase after that. The contraction still exists because the depolarization still continues. If you remember, we had a plateau phase that doesn't allow sudden depolarization followed by sudden repolarization. We have this kind of plateau, which was mediated by the fact that we have calcium influx and cessation of potassium outflux, if you remember. Okay, so the pressure inside your ventricles will continue to rise, right, because of the depolarization and the continuing contraction of the ventricular muscle. Once it exceeds the pressure in the ventricles, once it exceeds the pressure in the aorta, we're talking about the left side, then it will open up the aortic valve, and therefore the pressure in the aorta and in the left ventricle will both increase simultaneously. Now they are connected together. They're almost like one chamber now. The aorta and your left ventricle became one because you opened the valve, and therefore the pressure inside them will reach to approximately 120. Okay? The opening of the aortic valve allowed the blood to go from the ventricle, left ventricle in this case, to the aorta. Therefore, you can see a drop in the left ventricular volume. Sounds good? So this is an easier phase and easy to understand. Continuing contraction, because continuing depolarization of the ventricular muscle will continue to increase the pressure to the level that it exceeds the aortic pressure. Again, same events happen on the right side, but this is the left, so will exceed the pressure on inside the aorta. That allows the aortic valve to open. When the aortic valve to open, now the two chambers, the aorta and the left ventricle, are connected together, and therefore the pressure continues to rise, as you can see here in both of them. And the continuing rise of the ventricular pressure and the flow of the blood from the ventricle to the aorta will result in the drop that you see here in the ventricular volume. The blood left. Where did it go? To the aorta. Sounds good? Excellent. So let's go to the next step. What happens next? Well, at the end of the depolarization, of the ventricles, then it's followed by repolarization of the ventricles. And in the EKG, the repolarization of the ventricles is illustrated or shown as the T wave. Sounds good? Okay. Well, repolarization, what does that indicate? It indicates the muscle fiber will start to relax, right? The cardiomyocytes are going to start, the ventricular muscle is going to start relaxing. So when you relax the ventricles, in this case the left, the pressure inside the left ventricle is going to drop. As it drops, remember, the pressure was equal in the left and right, so when it drops, I'm sorry, not the left and right, between the left ventricle and the aorta, as it drops, as the pressure drops, the pressure also in the aorta will drop, right? Because they're same chamber. But if it goes below somewhere around 80 or 90, the blood in the aorta will try to go back to the left ventricle, and that is not going to be allowed. You see, pressure, the flow of volumes always follows the pressure gradient from the area of high pressure to the area of low pressure. And if the pressure here in the aorta exceeds the pressure in the left ventricle, the blood will try to go from the left ventricle into the aorta. But that is not allowed, because we have something here called aortic valve. It will shut down. In the right side, we will have also the pulmonary valve that will prevent the blood from going back from the pulmonary artery into the right ventricle. So both of them will shut down, therefore preventing the blood to go from the major arteries into the ventricles. The shutting down of the valves, if you go down here, it will produce to you the second heart sound. Sounds good? Okay. Well, once the ventricles started relaxing, it doesn't pump blood anymore into the aorta. Matter of fact, the aortic pressure is now exceeding that of your ventricular pressure, and not having any blood leaving, that gives you this flat line in the volume, right? In the volume of what? Of the left ventricle. Nothing is changing at that point, because what you did is you closed down the valve, right? You closed down the valve, and now the ventricle is relaxed, and that is what we call end systolic volume. So we had two volumes that we need to remember here. There's one of them is called end diastolic volume, and the end diastolic volume is the volume you reached right after your right before your atrioventricular valves closed. It's the maximum amount of blood that is in a regular cycle that is in the ventricle. We call that end diastolic volume. Once the blood is ejected out of the ventricle, we still have blood. Don't think that the ventricles become empty. No, it still has some blood left in it, and that's what we call the end systolic volume. If you take the end diastolic volume, subtract from it the end systolic volume, that gives you a very important volume. We call that stroke volume. You take the stroke volume, multiply the stroke volume by the heart rate. It gives you yet another term that you need to remember, which is called cardiac output. Cardiac output. So the stroke volume is the end diastolic volume minus end systolic volume. That's the stroke volume. Multiply that by the heart rate. That will be your cardiac output. Okay? So let's see again these events that took place here. The repolarization of the ventricular muscle will indicate that the ventricular systole is ending, no more contraction of the ventricles. Then the ventricles will relax, and the relaxation will cause the pressure inside the aorta on the left to exceed that of the left ventricle, and the blood will try to flow back. That will be prevented due to the presence of the aortic valve, shutting the aortic valve on the left, shutting the pulmonary valve on the right. That will cause the second heart sound. In the meanwhile, the ventricular pressure will continue to drop till it goes back to the very original pressure that we had, which is around 4 or less, around 2 even. Sounds good? All right. So then the very last stage here. Okay, what happens? Well, we have continuing relaxation of the ventricles. Okay, what does that mean? Well, the pressure has dropped until the pressure here goes below the pressure inside the atria. Please remember that the atria, while the ventricle is being contracting, the atria continue to receive blood on the left side from your pulmonary artery, from the pulmonary veins, and on the right side from the superior and inferior vena cava. So now the atria is full, and the atrial pressure now, which is this green line, has exceeded the ventricular pressure, and therefore at this point here, when the ventricular pressure is lower than the atrial pressure, then the valve is going to open. The atrioventricular valves, the mitral on the left and the tricuspid on the right, and that will cause rapid filling of the ventricle. That's what we call the early diastole. The early diastole will cause rapid filling of your ventricle, and you can see that here in the ventricular filling in the volume, that you did not need the P wave. Remember the P wave? You don't need the P wave. You don't need the depolarization and the contraction of the atria in order to start the filling process of the ventricles. That happens way before the contraction of the atrium, and that's why some people can live almost normally with ventricular fibrillation, which means that the ventricles are not really contracting at all. They act like a bag that's full of worms, and they don't have any functional capacity of pumping the blood. The passage of the blood from the atria to the ventricle, to the large extent, not completely, but to the large extent of it, happens passively from an area of high pressure to the area of low pressure, without the contraction and or the depolarization that causes the contraction of the atria. Sounds good? All right. So let's see what happens then next. We have yet another P wave, and this other P wave will cause depolarization of the atria. You got it. And the depolarization of the atria will increase the pressure inside the atria, and that will increase the filling. So now all of this is considered ventricular filling. We have the early filling or the rapid filling that happens without any help of the atrial contraction, and then later on we're going to have some additional filling that happens because of the atrial contraction. And if you remember, this is how we started the whole thing. As the depolarization wave reaches the ventricles, then you have yet another QRS complex. Another QRS complex is going to increase the pressure inside the ventricles. As the pressure rises in the ventricles, it's going to exceed the pressure in the atria, causing the first heart sound to happen. And now the blood has nowhere to go. It's the area between the closure of the AV valves and the opening of the aortic on the left and the pulmonary on the right. It's the area between these two events. We call that isovolumetric contraction phase. But there is also another isovolumetric phase, which is what we call the isovolumetric relaxation phase, which is really this phase in which, check this out, the aortic valve has closed. So now there is no filling, right? The ventricle is holding the same volume, but the pressure inside the ventricle is still higher than the pressure inside the atria. So the AV valve, the atrioventricular valve, did not open yet. So that means the pressure is held still, not the pressure, I'm sorry, the volume is held still, right? No blood coming in, no blood going out. So we call this phase isovolumetric. Nothing is changing in the volume. So we have isovolumetric relaxation phase and isovolumetric contraction phase. You see the straight line in the volume and the straight line in the volume. Call this part here isovolumetric ventricular contraction phase. This is isovolumetric ventricular relaxation phase. Sounds good? So if we want to be technical, the isovolumetric contraction phase is between the closure of the atrioventricular valves and the opening of the pulmonary and the aortic valves. And the isovolumetric relaxation phase is the area between the phase between the closure of the aortic and the pulmonary valve to the opening of the atrioventricular valve. Once you look at the Wiggers diagram in the way that we just described together, it's going to be very easy for you to summarize even the entire chapter, because now you understand how you link the EKG with pressure gradients that take place in the atria and the ventricles and in the aorta, and also relate that to the ventricular filling and the ventricular ejection. You understand now certain terms like the end diastolic volume, end systolic volume, the stroke volume, the isovolumetric contraction phase, the isovolumetric relaxation phase. Now I hope you understand the Wiggers diagram in a way that is much easier to remember, and I hope this will help you wrapping up this very important chapter and in reviewing for the exam and future studies as well. Have a great day.